Welcome to Psych Talk. I am your host, Jessica Lee, a licensed clinical psychologist. It is my mission to motivate, inspire, and educate you on everything psychology, mental health, and self-growth. Although topics discussed on this podcast are similar to therapy, Psych Talk is not a replacement for therapy and is for educational and entertainment purposes only. Whether you are a mental health professional or student in the social science field, are interested in psychology and mindset shifts, or are just interested in gaining skills and knowledge to grow into the best version of yourself, this podcast is for you. My hope is to provide you with knowledge and skills that you can implement in your daily life that add up to make a big impact. Let's dive into today's episode. Hey everyone, welcome back to Psych Talk, and thank you so much for joining me for today's episode. I know we are at the end of April, but April is Autism Acceptance Month, sometimes still referred to and previously known as Autism Awareness Month, but I will get into that difference here shortly. So I only have done one other episode on autism on this podcast, which was episode 109, entitled Autism Spectrum Disorder with Dr. Jenica Engler back in 2022. And so I figured it was time to do another episode. I was planning on doing this episode anyways for Autism Acceptance Month. However, with RFK Jr.'s recent inaccurate comments about autism and his claim of finding a quote unquote cure by September makes this episode even more timely. So, a little bit of background about me and my knowledge and involvement with the autistic community. I am not autistic. I want to make that very clear that the information I will be sharing in this episode is not based on lived experience, but rather research and experience working with autistic individuals. So I know this episode will be coming from the perspective of a non-autistic, otherwise known as an allistic individual, but I hope to provide rich information, even though I don't have lived experience. I do want to emphasize, however, please listen to autistic voices when it comes to the topic of autism. Despite not being autistic, I do have a lot of experience working with autistic individuals. So my postdoctoral fellowship, which is the year of training I got after I got my PhD that I have to complete to be eligible for licensure, was in developmental pediatrics. And during my fellowship, I primarily conducted assessments on children and teens with neurodevelopmental and learning disabilities. I got trained in the ADOS-2, which is the Autism Diagnostic Observation Scale, second edition during my internship, as well as more formal training during my fellowship. And during my fellowship, I was also part of the SC LEND program, which is Leadership, Education in Neurodevelopmental and Related Disabilities. I won't go into what the LEND program is here, but I can link information in the show notes if anybody is interested. Currently, although I do not specialize in neurodevelopmental disorders, I work with a number of patients with a variety of neurodevelopmental disorders. In the hospital, it's not uncommon for me to work with children and teens who have comorbid neurodevelopmental disorders and chronic illness. And on the outpatient side, I have a number of clients who are autistic. As an interesting side note, there is emerging research on the overlap between autism and gender diversity. If you are not tuning in for the first time and know anything about me, you know I work with a lot of LGBTQ plus youth, and anecdotally, most of the autistic clients I see are also gender diverse. So if you are at all interested in learning more about that overlap, let me know and I can do a whole episode on it. But a good starting point would be this book called Gender Identity, Sexuality, and Autism by Eva Mendez and Meredith Maroney, which summarizes some of the current research and includes interviews from autistic individuals about their gender and sexual orientation. So all of this long-winded thing to say that I am not diagnosed with autism. I would not say that I'm an expert in autism because it is not my primary clinical nor research focus. And I do have a lot of experience and knowledge working with autistic individuals. And I think it's really important for me to be transparent about all of that upfront as we navigate this episode together. So without further ado, let's get into the episode. So first, I want to discuss the differences between autism acceptance and autism awareness. as I said at the top of this episode, April is Autism Acceptance Month, but it was previously called and still sometimes called Autism Awareness Month. So, what is the difference? Autism awareness really focuses on understanding and recognizing autism. It may involve psychoeducation on what autism is, learning about the various presentations of autism, raising public awareness of autism, and combating misconceptions about autism. Autism acceptance takes awareness a step further by not only understanding and recognizing autistic individuals, but embracing them for who they are, valuing autistic individuals' unique strengths and differences, as well as promoting inclusion and understanding. This may look like advocacy for disability rights and inclusion of autistic individuals in various settings, listening to the voices and lived experiences of autistic individuals, challenging ableism, and promoting policies and practices that are inclusive of autistic individuals. So, the shift from autism awareness to autism acceptance happened in 2021 as a growing call for inclusion and acceptance of autistic individuals. So, to give some examples of awareness versus acceptance, and we're going to talk more about this throughout the episode, you may be aware that some individuals with autism struggle with making eye contact when speaking. Acceptance would take this awareness a step further and may look like accepting that an atypical eye gaze does not mean the person is uninterested or not paying attention to what you are saying. It may look like not asking the person to make eye contact in a discussion or providing education on atypical eye gaze when in a situation in which you hear maybe a neurotypical person tell an autistic individual to make eye contact. Awareness may involve recognizing that some autistic individuals may stim when they are excited, anxious, or just thinking, or for a variety of other reasons. Whereas acceptance may look like providing a space for the autistic individual to stim or providing them with things such as fidgets or a chair that spins or an exercise ball to help with stimming. So, like I just said, we will talk more about autism acceptance and awareness later in the episode, but I wanted to start the episode just by discussing a few of the differences between acceptance and awareness. So, next, I want to talk about what autism spectrum disorder actually is. So, autism spectrum disorder is a neurodevelopmental disorder, meaning it is a condition that affects how the brain functions. Neurodevelopmental disorder symptoms appear in early childhood and impact one's functioning. It should be noted that all neurodevelopmental disorders exist on a spectrum, which means the level of impairment one experiences also exists on a spectrum. Thus, two individuals with the same neurodevelopmental diagnosis can experience very different degrees of symptoms as well as deficits, despite having the same diagnosis. So, before I get into the diagnostic criteria for autism spectrum disorder as we know it today, I think it's important to look back over the history and development of the diagnosis to gain an understanding of how we previously conceptualized autism and how we conceptualize it today. If you follow me on social media, you probably saw the video I made on this. So, I'm going to include the same content that I did in the video, but I felt it was important to include it in the podcast. So in 1943, Leo Kanner, who was an Austrian American psychiatrist and physician, first described autism when he wrote about children with, quote, extreme autistic aloneness, end quote, delayed echolalia, and quote, anxiously obsessive desire for the maintenance of sameness. So in 1968, autism was included in the DSM-2. And so that is the Diagnostic Institutional Manual of Mental Health Conditions or Mental Disorders. And that is what we, at least in the United States, as well as some other countries, use to diagnose neurodevelopmental, mental health, substance use disorders, etc. So in 1968, in the DSM-2, autism was defined as a form of childhood schizophrenia marked by a detachment from reality. And I want to make clear, we're going to talk about some of the comments that have been going around the internet and from the words of our current administration recently. But there's this number that's been thrown out about, well, autism used to be 1 in 10,000 and now it's 1 in 31. And we'll talk about the rise in autism rates over time. The 1 in 10,000 number comes from the 1960s. So when autism was defined as a form of childhood schizophrenia. So then in 1980, the DSM 3 came out, and autism was defined as a pervasive developmental disorder characterized by a lack of interest in people, severe impairments in communication, and bizarre responses to the environment. Additionally, the onset of these symptoms had to happen before 30 months of age. Then in 1987, the DSM 3 revised version came out, and autism was revised by adding a diagnosis on the mild end of the spectrum, known as pervasive developmental disorder not otherwise specified, or PDD-NOS, and dropping the 30-month onset requirement. So we had what we consider like classic autism, and then we had PDD-NOS. And then in 1994, the DSM-4 came out. And this is where autism was first defined as a spectrum. But the spectrum was defined through 5 separate conditions with distinct features. So we had autism, like we did in the DSM-3. We had pervasive developmental disorder not otherwise specified, like we had in the DSM-3 revised version. Then we also had Asperger's disorder, which was considered quote unquote high functioning autism. We had childhood disintegrative disorder, which was abbreviated to CDD, and this was characterized by severe developmental reversals and regressions, as well as Rett syndrome, which affects movement and communication primarily in girls. Then in 2013, the DSM-5 came out, and this is where autism became autism spectrum disorder, characterized by 2 groups of distinct features. First was persistent impairment in reciprocal social communication and social interaction, and the second is restricted repetitive patterns of behavior. The DSM-5 eliminated Asperger's syndrome, eliminated PDD-NOS, as well as classic autism, but added social communication disorder to include children with only language and social impairments, but that did not have those restricted repetitive patterns of behavior. Childhood disintegrative disorder and Rett syndrome were removed from the autism category as well. There were also some slight changes when the DSM-5 text revision came out in 2023, including in the specifier changing the language from, quote, another neurodevelopmental, mental, or behavioral disorder to, quote, another neurodevelopmental, mental, or behavioral problem. So the word switched from disorder to problem. And additionally, the phrase manifested by the following was revised to read as manifested by all of the following to improve the intent and clarity of wording. So what is the diagnostic criteria for autism spectrum disorder? So I'm going to literally read to you all the diagnostic criteria from the DSM-5 TR. So diagnostic criteria A, persistent deficits in social communication and social interaction across multiple contexts as manifested by all of the following currently or by history. Examples are illustrative and not exhaustive. A, deficits in social emotional reciprocity ranging, for example, from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interests, emotions, or affect to failure to initiate or respond to social interactions. B, deficits in nonverbal communication behaviors used for social interaction ranging, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures, to a lack of total facial expressions and nonverbal communication. And C, deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts to difficulties in sharing and imaginative play or in making friends to absence of interest in peers. So that was the social category. Next, we go into B, which is restricted repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the following, currently or by history. Examples are illustrative, not exhaustive. A, stereotype or repetitive motor movements, use of objects or speech, for example, simply motor stereotypes, lining up toys or flipping objects, echolalia, idiosyncratic phrases. B, Instance on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. For example, extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to take the same route or eat the same food every day. C. Highly restricted, fixated interests that are abnormal in intensity or focus. For example, strong attachment to or preoccupation with unusual objects excessively, circumscribed, or perseverative interests. D. Hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. For example, apparent indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascinations with light or movement. C. Symptoms must be present in the early developmental period, but may not become fully manifested until social demands exceed limited capacities or may be masked by learned strategies later in life. D. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. E. These disturbances are not better explained by intellectual developmental disorder, otherwise known as intellectual disability, or global developmental delay. Intellectual developmental disorder and autism spectrum disorder frequently co-occur. To make comorbid diagnoses of autism spectrum disorder and intellectual developmental disorder, social communication should be below that expected for general developmental level. Note, individuals with a well-established DSM-4 diagnosis of autistic disorder, Asperger's disorder, or pervasive developmental disorder not otherwise specified should be given the diagnosis of autism spectrum disorder. Individuals who have marked deficits in social communication, but whose symptoms did not otherwise meet criteria for autism spectrum disorder, should be evaluated for social pragmatic communication disorder. Then we have to go on to specify certain things. So that was the diagnostic criteria. Then you have to specify current severity based on social communication impairments and restrictive repetitive patterns of behavior. So this is where we have requiring very substantial support, requiring substantial support, or requiring support. And I'm going to go more in depth in the severity levels here in a moment. You also have to specify if it's with or without accompanying intellectual impairment and with or without accompanying language impairment. You also have to specify if it's associated with a known genetic or other medical condition or environmental factor, or associated with a neurodevelopmental, mental, or behavioral problem, as well as you specify if it's with catatonia. So now let's talk about the severity levels for autism spectrum disorder. And this is examples of level of support needs. And so it's broken into 3 levels. So level 3 is requiring very substantial support. So when we look at social communication, we would see severe deficits in verbal and nonverbal social communication skills that cause severe impairments in functioning, very limited initiation of social interactions, and minimal response to social overtures from others. For example, a person with few words of intelligible speech who rarely initiates interactions, and when he or she does, makes unusual approaches to meet needs and only responds to very direct social approaches. With regard to restricted repetitive behaviors, we may see inflexibility of behavior, extreme difficulty coping with change, or other restricted repetitive behaviors markedly interfere with functioning in all spheres, great distress, difficulty changing focus or action. Now, level 2 is requiring substantial support. And so for social communication, this might look at as marked deficits in verbal and nonverbal social communication skills, social impairments apparent even with supports in place, limited initiation of social interactions, and reduced or abnormal responses to social overtures from others. For example, a person who speaks simple sentences, whose interaction is limited to narrow special interests, and who has markedly odd nonverbal communication. For restricted repetitive behaviors, we would see inflexibility of behavior, difficulty coping with change, or other restrictive repetitive behaviors appear frequently enough to be obvious to the casual observer and interfere with functioning in a variety of contexts, and then distress and or difficulty changing focus or action. Then we have level 1, which is requiring support. Social communication would look like, without supports in place, deficits in social communication cause noticeable impairments, difficulty initiating social interaction, and clear examples of atypical or unsuccessful responses to social overtures of others. May appear to have a decreased interest in social interactions. For example, a person who is able to speak in full sentences and engages in communication, but whose to and fro conversation with others fails, and whose attempts to make friends are odd and typically unsuccessful. For restricted repetitive behaviors, we may see inflexibility of behavior that causes significant interference with functioning in one or more contexts, difficulty switching between activities, problems of organization and planning hamper independence. So now on to the next topic is what causes autism. So if you have been following the news recently, you will know that RFK Jr. has claimed to find the cause of autism by September 2025. There are reports that that statement has now been like taken back a little bit, and it's like some of the causes, or we're working towards finding the cause by September 2025. But regardless, the statement was made. And so not only does scientific research not have a timeline, we already have an abundance of research contributing to the causes of autism. And yes, I said causes because autism does not have a single known cause. And given the complexity of the disorder and the wide range of symptom severity and presentations, research suggests that the cause of autism is likely multifactorial, meaning both genetics and the environment play a role. And so that's what I'm going to get into here, a summary of what we have in the literature thus far. I also want to make it clear, because it might have come off the wrong way, I am not against researching further causes of autism. I think, I mean, a lot of mental health needs more research, but I am in full support of autism research continuing, ways that we can better help autistic individuals and their families. My point of bringing up the RFK comment was like, we already have an abundance of research and we have not pinpointed to one cause because, like I said, it's multifactorial. Also, research doesn't have a timeline, like I said. So when we look at genetics, there is not one gene, to our knowledge thus far, that causes autism, and several different genes appear to be involved. So for some children, autism spectrum disorder can be associated with a genetic disorder, such as Rett syndrome or Fragile X syndrome. For other children, genetic changes or mutations may increase the risk of autism spectrum disorders. Other genes may affect brain development or the way brain cells communicate, or they may determine the severity of symptoms. Some genetic mutations seem to be inherited, where other genetic mutations occur spontaneously. So the heritability rate of autism spectrum disorder is estimated to be around 80 to 90%, meaning genetics play a significant role in the development of ASD. So for comparison purposes, to show how high of a rate that is, bipolar disorder has a heritability rate of 70 to 90%, and schizophrenia has a heritability rate of 70 to 80%, whereas depression has a rate of 40 to 50%, and anxiety has a rate of 30 to 50%. When looking at environmental factors, we can divide these factors into three categories. So we have the prenatal, so those before birth, natal during birth, and postnatal after birth. So prenatal environmental factors may include, I want to make it abundantly clear that all the things I'm about to list is not exhaustive. I'm sure there are things I missed, but from digging into the research. So physical health of the pregnant person, such as presence of metabolic syndrome or viral infections in the first trimester, infections that are accompanied by fever in the second trimester, specifically also raise risk for autism in the newborn. Mental health issues in the pregnant person, such as depression and anxiety, parental age, especially paternal age above 34 years, certain prenatal medications, such as anti-epileptic drugs and antidepressant medications, lower socioeconomic status, likely due to a complex interplay of factors, including maternal stress, access to healthcare and resources, and environmental exposures. Natal environmental factors may include fetal complications, which may lead to a lack of oxygen, umbilical cord complications, bleeding during pregnancy, and premature or late birth. Postnatal environmental factors may include jaundice. Although this association is not definitively established, there is some research that suggests neonatal jaundice, specifically in babies born between 35 and 37 weeks, have a higher risk of autism and developmental delays. However, other studies have found no association. Postnatal infection. So, an example of this is CMV. So, cytomegalovirus. I hope I said that right. Cytomegalovirus. All I know is I was exposed to CMV in the hospital when I was pregnant with my son and had to go get extra blood work, but I was fine. Side note. So this is related to the viruses that cause chickenpox, herpes simplex, and mono. Vitamin deficiencies, specifically vitamin D, low levels of care, and chemical exposures. So research has examined a wide range of chemical and pollution related to autism. And some that have shown associations with autism include traffic related air pollutants, some metals. So, for example, mercury, cadmium, and lead, some pesticides, which I would try to name for you, honestly, but I'm already struggling to name the other chemicals and diseases. So, I'm not even going to try. And then research on chemical exposure, though, is still developing, and the research we have is mixed or inconclusive. So I do want to note and make it very clear that when we are talking about environmental factors, the things I have listed have found some association with autism. It does not mean they are causal factors, nor does it mean that everyone who has been exposed to or experienced these things will have autism. These are just some of the things that have been examined in the research, albeit plenty of it is mixed, and have found to be associated with increased autism risk. I'm going to say, I was going to say, I don't know if I need to say this. So, one of my personal pet peeves when we talk about like causes of autism is we in research cannot find causal factors unless a randomized controlled trial or an experiment where individuals are assigned randomly to one of two groups or three or more, depending on what you are looking on, and everything else is controlled for. And the only difference in outcome is the dependent variable. So, a lot of this research is just looking at correlation or associations because we cannot randomly assign, for example, exposing certain individuals to certain toxins and not others, and controlling for every other possible influence and determining if those that are exposed have autism and those who aren't don't have autism. And the reason I bring that up, because a lot of the research, like I said, is correlational. So we do have evidence, that genetics plays a strong role. We have some evidence that certain toxins or chemicals or pollutants increase risk, but it doesn't make it a causal factor. So, with that being said, I also would not do my due diligence on this podcast if I did not at least touch on vaccines and autism, because there is so much rhetoric about vaccines and autism. So, I'm going to put it as straightforward as possible. As of current science, there is no scientific evidence that supports the idea that vaccine cause autism. And part of why I just gave that long-winded explanation about the causal factors, things like that, you can't randomly assign people to get a vaccine or not. Like that is not ethical research. So yes, there based on our science currently, there is no scientific evidence that vaccines cause autism. So in 1998, a man named Andrew Wakefield published a paper claiming there was a link between the MMR vaccine and autism. Scientists to this day have never been able to replicate these findings. And it was determined that Andrew Wakefield faked his data for the paper with the goal of misleading people so he could make money selling autism diagnostic kits as well as a competing measles vaccine. So he was not anti vax. He actually wanted to create his own vaccine that was just going to be a measles vaccine. It wasn't going to be the combined MMR, but did not feel it would be successful unless the public no longer had trust in the MMR vaccine. Fake data aside, he also only included 12 children, which is an extremely small sample size. Wakefield lost his license to practice medicine because of this. The journal that published the paper withdrew it. And since then, like I said, no scientists have been able to show any link between vaccines and autism. I also want to make it very clear I am not denying that vaccine injuries exist. They do. They could be things like shoulder injuries resulting from vaccinations, Guillain-Barre syndrome, which are considered two of the most common vaccine injuries. And then there are some severe vaccine injuries, such as encephalitis, which is inflammation of the brain, although that's rare and significantly less common than, say, a shoulder injury. However, once again, there's no scientific evidence supporting the association between vaccines and autism. I want to conclude this section by saying we do have an abundance of research looking at underlying contributors to autism, and I am sure the research will continue over time. I do want to acknowledge that there are things I have likely not addressed in this episode, such as specific genes or other environmental factors. However, to summarize what I've said, autism results from a combination of genetic and environmental factors, with a significant proportion of autism resulting from genetics. So, another hot topic that's been talked about here recently, why are we seeing an increase in autism diagnoses? So, a few days before recording this episode, the CDC released new data suggesting 1 in 31 children aged 8 in the United States has been diagnosed with autism, which is about 3.2%. This is an increase from 1 in 36 that was found in 2020. So, then, if we go back to the year 2000, the prevalence rate of autism was 1 in 150. So, this has been a significant topic of discussion recently, with both President Trump and RFK Jr. speaking out on the need to find the cause of autism, as well as the reason for the increase. I am going to talk about some of the theories for why we have seen increases in autism. However, before I jump into that, I just want to share a few more facts and statistics about autism. So, ASD is reported to occur in all racial, ethnic, and socioeconomic groups. However, according to the research provided in the DSM-5 TR, so this research is from 2022, prevalence appears to be lower among Black at 1.1% and Latinx 0.8% children compared with white children, which at that time was 1.3%, even after the effect of socioeconomic resources is taken into account. Autism is over 3 times more likely common among boys than girls, which I think is something important to remember as I talk about the increase rates. So now on to some of the reasons we see increases in autism diagnosis over time. First is expansion of diagnostic criteria. If you're on social media or listen to RFK Jr. or President Trump, and I shared this stat earlier in the episode, if you've heard them speak on autism, you've probably heard them talk about how autism used to be 1 in 10,000 and now it's 1 in 31. And if we look at those raw numbers, that absolutely sounds like a dramatic difference. However, we need more context, which would tell us that the 1 in 10,000 number comes from the data in the 1960s and 1970s, depending on where you look. And like I said earlier in this episode, when we were talking about the evolution of autism, in 1968, autism was defined as childhood schizophrenia, characterized by detachment from reality. The definition of what autism was at the point in time that it was 1 in 10,000 was so narrow that it's unsurprising that it was that rare. So, the first reason why autism rates have increased is the expansion of diagnostic criteria. I'm not going to rehash what I already went over in this episode about the evolution of the criteria, but hopefully you're listening, or if you need to go back, feel free to go back and listen to get a sense of how it has changed over time. But even if we compare like the DSM-4 to the DSM-5, the DSM-4 was the first DSM to consider autism a spectrum, but it included 5 different diagnoses, only one of which was autism. And then in the DSM-5, PDD, NOS, and Asperger's syndrome were eliminated and included in the diagnosis of autism spectrum disorder. And like I read when I was reading the diagnostic criteria, if somebody previously had a diagnosis of Asperger's disorder or PDD NOS under the DSM-5, they needed to be diagnosed with autism spectrum disorder. So even if we only include individuals previously with an Asperger's or PDD NOS diagnosis, we would naturally expect those numbers to be higher when the new DSM came out in 2013. So when we broaden the diagnostic criteria to include more symptoms, more people are going to meet criteria for autism. The next reason we have seen increased rates in autism is there are better assessments and screeners. So, the Autism Diagnostic Observation Schedule, known as the ADOS, is considered one of the gold standards for autism assessment. It was originally developed in 1989 to address the limitations of existing diagnostic tools, which often lacked standardized criteria, varied in validity, and were less effective at identifying individuals with lower support needs. So, as we talked about earlier, now we have 3 levels. So, lower support needs would be level 1. So, to give some numbers, in the 1980s in the United States, autism rates range from 0.1 to 0.4 per 1,000 children. Then in the 1990s, that rate increased to 2.0 to 7.0 per 1,000 children. So after we got this better assessment tool, we saw an increase in diagnoses. The ADOS 2 was then published in 2012, which included updated norms, improved algorithms for modules 1 to 3, which are given based on age and ability, and a new toddler model for assessing children 12 to 30 months. The scoring algorithm was also revised to align with the changes of the DSM-5 criteria. So, to give some numbers again, in 2012, the autism rate in the US was 1 in 69, and by 2014, it was 1 in 59, which we need to consider both the second version of the ADOS and the DSM-5 came out in that timeframe. Further, the Modified Checklist of Autism in Toddlers, otherwise known as the MCHAT, is an autism screener used in children 16 to 30 months of age and was developed in the 1990s and then revised, and the revised version came out in 2009. So the MCHAT-R became a standard screener in pediatrics after its publication, meaning children were being screened and identified earlier and more precisely based on the revisions. We're also screening all the children. So if we're screening every child that walks in, we are bound to catch more children that have elevated scores, potentially indicating autism. We can even look across states currently to see how the implementation of assessment and screeners impact diagnostic criteria. California has the highest prevalent rate of autism, with a rate of 53.1 per 1,000 8-year-olds, compared to, say, Texas, with a rate of 9.7 per 100,000 8-year-olds. According to the CDC, this is likely linked to California's intense push for early screening and assessment, thus identifying children earlier. Another reason we have seen an increase in autism rates is adults, women, and girls are seeking and receiving diagnoses. So, autism has been considered a male dominant condition. And as I mentioned earlier, we still see males being diagnosed 3 times more than girls. However, research suggests that autistic females are underdiagnosed, misdiagnosed, or later diagnosed. Further, females also have different and more nuanced behavioral profiles. So, a 2024 study by Harrop and colleagues examined autism rates among females over a 20-year period and found that females diagnosed with autism increased at a greater rate compared with males, and age of diagnosis remained consistently higher for females. Another 2024 study, led by Kaiser Permanente researchers examining autism diagnoses over the 2011 to 2022 period among U.S. children and adults, found increase in autism diagnosis across the study period for all groups. However, there were faster increases among certain groups. So the greatest relative increase in diagnosis rate from 2011 to 2022 occurred among 26 to 34-year-olds, with a 450% increase. Further, increases were greater for females compared to males for both children. So in girls, there was a 305% increase versus boys was a 185% increase, and adults. So for women, it was a 315% increase versus 215% increase for males. Thus, if girls, women, and adults in general are now seeking out and being diagnosed with autism, either because they were previously missed or autism assessment wasn't readily available to them previously, we are once again going to see an increase in the number of people diagnosed with autism. Another reason we may be seeing the increase in autism rates is autistic individuals most often are not being institutionalized anymore. And I say most often because those who still have that level 3 requirement of needs, especially into adulthood, often are put in group homes or other type of care facilities. We don't really call them institutions anymore. But if you know any history about mental health care in the United States, as well as other developmental countries, you will know that institutionalization was the quote unquote treatment for those with mental illness. So, autistic individuals were frequently institutionalized. Like if you had a diagnosis of autism, you were institutionalized up to as recently as the 1980s, coinciding with the deinstitutionalization movement in mental health care. Like I said, I'm not negating that some autistic individuals are still put in homes of some sort these days, especially those requiring the highest level of support needs. There was a huge stigma about autism during the institutionalization period, and children were often just sent off, kept out of public, and lived their lives away from their families, with their families ever rarely even talking about them. One reason at this time for the stigma was the idea that autistic children came from what we called, quote, refrigerator mothers, which was a theory that suggested that autism was due to lack of parental, specifically maternal, emotional warmth. The society looked down on not only autistic children, but also their parents. So parents would send their autistic children away and not talk about them because parents did not want to be blamed for causing autism. I want to make it clear that theory has been debunked. Thus, with the deinstitutionalization, we are lessening the stigma of autism by allowing autistic children to grow into autistic adults and be in the public eye and live full lives. Autistic adults are also having children. So, as I established earlier, the research suggests that autism has an 80 to 90% heritability rate. If autistic children are growing into autistic adults and they are having kids of their own, that increases the likelihood that more children are being born genetically predisposed to having autism. It's just a fact of life. We also see a decreased stigma and increased awareness of autism. I want to make it clear stigma about autism still exists. Although we now recognize that autism is not caused by like refrigerator mothers, as I mentioned a few moments ago, the stigma is still there, although it is less than it once was. When we destigmatize any mental health, neurodevelopmental, or other health condition, it increases the likelihood that individuals are willing to seek out a diagnosis and get help for what they themselves or their child is experiencing. We have also seen an increase in autism awareness, which leads to greater understanding of the condition, improvements in screening and diagnostic tools, and leads to increased diagnoses. Further, when people have language to describe how they experience the world or an understanding of behaviors they see in their child and are able to bring that to their own doctor or their child's pediatrician because they have a name for it, it helps with identification and assessment and the diagnosis of autism. The increased awareness and increased diagnosis also has led to greater demand for services and support, such as early intervention programs, specialized education, and therapy. And if we have more supports and services, more people may be willing to seek diagnosis because they know the supports are available. People having children later in life. I mentioned earlier when talking about environmental risk factors that older age of parents is associated with an increased risk of autism. There is a societal trend in developed countries of delaying childbirth, and thus, if individuals are having children at later ages and older age increases risk of autism, that may be another contributing factor. Another contributing factor is children being born prematurely. Children who are born prematurely, as I previously stated, are also at heightened risk of autism. However, thanks to advances in medicine and neonatal care, more premature babies are surviving into childhood and even into adulthood. Thus, we may be seeing more instances of autism. A fun fact I like to frequently throw out there as another potential contributor to the increase in diagnosis of autism is that prior to the DSM-5, which came out in 2013, autism and ADHD could not be diagnosed together. So each was an exclusionary criteria for the other. But we now know from research that somewhere between 50 to 70% of individuals with autism spectrum disorder also present with comorbid ADHD, and 20 to 50% of those with ADHD are also autistic. So these disorders are highly comorbid, but prior to 2013 were unable to be diagnosed together. Thus, another potential contributing factor to the rise of autism diagnoses is that children and adults were previously diagnosed with ADHD and thus not allowed to be diagnosed with autism spectrum disorder too, even if they had traits and characteristics or met diagnostic criteria for autism. Now, like I keep saying throughout this episode, this list was not extensive. I am sure there are other contributing factors to the rise in autism diagnoses as well. Although I would personally argue that expansion of criteria, better screening and diagnostic tools, increased awareness, adults and girls being diagnosed with autism, and autistic adults having autistic children are likely some of the main contributing factors to the increases we have seen. But I know I possibly could not list all of the reasons. There's probably reasons that we are unaware of. Another takeaway, however, is the rise is due to multiple factors. It is not just one thing. Autism is a spectrum, it's very complex. Like I said, it's multifactorial in its cause, and it's going to be multifactorial in the increase in diagnoses as well. So, next, I want to talk about misconceptions about autism. There are a number of misconceptions about autism, and it is not possible for me to cover all of them in one podcast episode, especially since this one is already pretty lengthy for a solo episode. But clearly, I have a lot to say on this topic, and maybe I should have made another autism episode before now. But, anyways, I will try to highlight some of the common misconceptions about autism. So to start out strong, which is actually not a common misconception, I feel the need to address one of the comments RFK Jr. made about autistic children, that they will, quote, never pay taxes, they'll never hold a job, they'll never play baseball, they'll never write a poem, they'll never go out on a date. Many of them will never use a toilet unassisted, end quote. So if we go back to the levels I talked about earlier when discussing the diagnostic criteria for autism, about 26.7% of individuals who are diagnosed with autism are level 3. So they require substantial report. So it is true that some autistic individuals may never pay taxes, never hold a job, etc. So I don't want to negate the lived experience of level 3 autistic individuals or their families. But that is also not the majority of autistic individuals. And I know a lot of criticism he is facing is that he did not distinguish. There was no nuance. It was blanket statements until he said many of them will never use a toilet unassisted. I also want to make it clear, even if it was the majority of autistic individuals, it does not mean these individuals are less worthy than other individuals who do not have the same struggle, simply based on their ability to perform or not perform certain tasks. So, on to the next misconception, which is autism is a disease. And I realized I'm continuing the RFK Jr. comments, but this is a common misconception as well. It's not RFK Jr. alone saying autism is a disease. Autism is not a disease, it is a neurodevelopmental disorder. And since it is not a disease, it is also not something that can be quote unquote cured. Although we could argue that since there are environmental factors that play a role in the development of autism or that increase one's risk, we could try to lessen autism risk through some of those factors. The highly genetic component that involves multiple genes suggests that it's not a disorder that can be prevented nor cured, however. Another common misconception: autistic people are savants. So, this belief comes from how many movies and media portrayals of autistic individuals just portray them. Although some autistic individuals may have a special talent or be a savant, autistic people have strengths and weaknesses, just like non autistic individuals. So, being autistic does not necessarily make someone a savant. On the other end of the misconception spectrum, there is also this misconception that autistic people are intellectually disabled. If you recall from when I read the diagnostic criteria, a specifier for autism spectrum disorder is, quote, with or without accompanying intellectual impairment, meaning that the person diagnosing has to specify if the individual also has an intellectual disability. Thus, autistic individuals can have an intellectual disability, but not all do. Per the CDC in 2023, 37.9% of children with ASD also had an intellectual disability, so a little over 1/3. Another misconception: autistic people aren't social. Although autistic individuals may need support with social skills or have difficulties in social relationships, most autistic people enjoy having relationships and do not desire to be alone or have no social connection. The social challenges seen in autism may make it difficult to make or sustain relationships. However, it does not mean that social relationships are not desired. Next misconception: only children are autistic. And, I thought I was going to get away from the RFK Jr. comments, but alas, here we are again because he did make a comment. I guess by the time this episode's out, it's probably a couple weeks ago. But the other day, as I'm recording it, that he has never met an autistic adult. The reality is, there are both autistic adults and children. You don't grow out of it just because you turned 18. Another misconception: only boys are autistic. As we have already established in this episode, 2 times, boys are 3 times more likely to be diagnosed with autism than girls. However, people of any gender can be autistic. Girls in general are more likely to mask their autism and learn skills to interact with non autistic people better than boys, which tends to lead to later or misdiagnoses, as we mentioned earlier when talking about the increases in autism diagnoses. And lastly, the 2 misconceptions I have already touched on: autism is not caused by vaccines, and autism is not caused by bad parenting. As I said at the beginning of this section, there are probably many more misconceptions about autism. However, those were just some of the few. So, as we're wrapping up this episode, and I say wrapping up, and I feel like I'm going to talk for a while after this, I wanted to go back to what we first talked about at the beginning of the episode, which is the fact that April is Autism Acceptance Month. And I wanted to talk about, what does autism acceptance actually look like? Everything I have shared thus far in this episode would fall in the more autism awareness category. You are now aware of the diagnostic criteria. You are aware of the history of the diagnostic criteria, aware of, misconceptions that you could call out or inform people on, um, aware of reasons that autism may have risen over the past multiple decades. So we talked about awareness. What does acceptance look like? So when we talk about autism acceptance, I think it's important to discuss different systems and different ways each system can live out acceptance of autistic individuals. So, for example, we'll start with the family, because one could argue that the most critical acceptance starts in the family, based on how they do or do not accommodate, support, and accept autism. So this may look like recognizing and embracing neurodiversity, meaning they honor each individual's needs and strengths within the family. In parenting, this might be recognizing that parenting a neurodivergent child is different than parenting a neurotypical child, and adjusting parenting styles to fit individual needs. It is creating a safe and supportive home that allows for sensory regulation, neurodivergent communication, and connection. So this may involve normalizing stimming, creating a sensory safe room or corner where the autistic family member can go when overstimulated, celebrating and supporting your loved one's restricted interests, creating predictability and routine in the home, as change is often difficult for many autistic individuals. Next, let's move on to autism acceptance in the classroom setting. Autistic students may have different learning styles and needs compared to neurotypical peers. Embracing autism acceptance in the classroom means creating an environment which respects and accommodates both neurotypical and neurodivergent individuals, rather than separating them into a different classroom, which has historically been done. So, this might look like normalizing stimming, such as rocking or bouncing. One way to do this may be to have children sit on exercise balls or a chair that rocks to help accommodate them. I do want to note, I understand in the classroom setting, there is a balance of accommodating to ensure the stimming is not distracting or disrupting other students. However, with proper accommodations in place, it should help both regulate the autistic student's emotions and focus while minimizing distractions from other students. Keeping visual clutter to a minimum, as visually overwhelming environments can be overstimulating for autistic individuals. It can also be overstimulating for other neurodiverse individuals too. Encourage sensory regulation and or provide sensory breaks. This could look like taking breaks for the entire class where they engage in a calming movement like yoga or have a specific time of day that's low sensory, such as like low noise, low lighting, doing a meditation, or having like calm down corner. And then providing clear, direct instruction with both visual and written forms. This is not only helpful, once again, for autistic individuals, but also accommodates different types of learning styles. As a psychologist, I also think it's important to highlight what autism acceptance can look like in therapy. So many autistic individuals will seek out therapy, both related and unrelated to their autism diagnosis. However, many therapists are not trained to work with autistic individuals. I personally did not get any formal training until my internship year, which is my last year of my PhD program. And then I got more specific training my fellowship year. So, autism acceptance in therapy means recognizing that autistic people have unique strengths and challenges, and that therapy should be tailored to specific needs. It also means that the therapist understands the goal of therapy is not to quote unquote cure the autism or even make the individual appear more neurotypical. The caveat to that is unless the individual specifically has goals that they want to work on related to that. But rather, therapy is about supporting them in achieving their goals. So, some ways to embrace autism acceptance in therapy includes using identity first language. So, I've been doing that throughout this podcast, like saying autistic rather than person with autism, unless, once again, the client prefers a different term, because we always want to use what the client prefers. Taking the client's lead on establishing goals for treatment and ensuring you are not imposing goals that are intentionally or unintentionally trying to make them more holistic. Encourage and support sensory regulation by allowing clients to stim in session, providing a calm and low stimulating environment, providing a space for sensory exploration, reducing neurotypical demands for a conversation. So, for example, not expecting eye contact, asking preferences on broad versus specific questions, giving space for the client to answer if they may take longer to process questions or gather their thoughts. Consider alternative forms of communication if verbal for back and forth ever becomes too overwhelming. So, for example, allowing them to write or type on their phone or express themselves through art. Allow space in the therapy conversation for connecting over special interests, giving space at the end of session for decompression, and embrace divergent and nonlinear conversation. Educate yourself on non stereotypical presentations, such as in women, BIPOC folk, and genderqueer individuals. Advocate for autism acceptance outside of the therapy room. This could include writing accommodation letters for school or work, educating parents if the client is a minor or an adult who lives with their guardians, writing your legislators to advocate for more support and resources for autistic individuals. Autism acceptance in medical settings. Many individuals, whether they're autistic or not, experience anxiety or fear around medical settings. For autistic individuals specifically, medical settings and appointments can be challenging, whether that be due to sensory overload, pathologizing of symptoms on the part of the medical professional, or the medical professional not understanding autism, making the individual feel unheard or left feeling confused. As the medical field has traditionally been ill equipped to accommodate the needs of autistic individuals, it can lead to misdiagnosis or inadequate treatment. So, some ways to embrace autism acceptance in medical settings include offering various options for communication, so verbal, written, visual aids, communication apps, allowing for longer appointment times if needed, offering low sensory waiting areas in exam rooms, so making it a practice policy that no one can wear strong perfumes, for example. We actually have that in the hospital. Low level lighting, music or sound machines that are quiet and calming, using visual aids to prepare for medical procedures, allowing autistic individuals to voice record visits so they can re-listen to it at a later time to help with information retention, educating yourself if you're a medical professional on autism and commonly co-occurring conditions, and providing clear, straightforward communication and include what was discussed in the written discharge summary. Autism acceptance in the workplace. involves creating a culture that respects and values differences. So this may involve offering accommodations such as noise canceling headphones, offering flexible work environments and work hours when possible, creating multiple options for communication, providing clear communication about expectations, allowing for sensory breaks and alternative workspace options, providing trainings to supervisors on autism and more broadly, neurodiversity. And then autism acceptance in society. Autistic individuals have had a long history of being excluded and marginalized from society, which we highlighted earlier when talking about the institutionalization of autistic individuals. On a societal level, autism acceptance involves challenging stereotypes and promoting a culture of inclusion and understanding. This may look like advocating for policy changes that support the rights and needs of autistic individuals, whether that be in healthcare, for disability resources, or other means. Representation of autistic voices in media and public spaces, for example, having actually autistic actors play autistic characters in shows and movies. Accommodating for sensory needs in public spaces. So, an example of this, our local Walmart has sensory friendly hours. I believe it's from 10 to 12. I don't remember each morning, which involves low lighting and no music. In society, autism acceptance looks like challenging harmful stereotypes and promoting positive representations in the media, as well as supporting inclusion through equal opportunities and accommodations in education, employment, and public spaces. So I'm going to end there because I've been talking for a long time. And like I said, this is a longer solo episode, but I clearly need to do more episodes on autism. And I will do that in the future if you all are interested, because there is so much more I could say on this topic. And given the current conversation about autism and our socio-political climate, I feel like future episodes on autism will be relevant. But I am going to end on this. So given the recent comments made by RFK Jr. and the harm I personally feel he is causing, as well as so many autistic individuals feel, parents of autistic children, therapists who work with autistic individuals, and so many other feel that he is causing with his narrative. My friend Andrew Robinson and I, Andrew was previously on this podcast, episode 209, talking about ADHD, are working on a project together. So we are gathering poems and stories from autistic individuals who have written about their lives with the ultimate goal of reaching a representative and or senator who will be able to read the poems and stories on the House or Senate floor. Our goal is to center autistic voices of all ranges and needs and have their stories and art heard. So if you are interested in being part of this project or know someone who may be, the link to the Google form will be in the episode show notes. Now that that is out of the way, I hope this episode was informative. Please share it with anyone who you think would be interested. And as always, please rate, review, and subscribe to the podcast. This podcast, I say every time, would be nothing without you all. So I just appreciate you tuning in every week or every other week, or if you just randomly listen when you think a topic is interesting. I appreciate every single one of you. So thank you so much for joining me for this episode. Share it with a friend, and I will catch you in the next episode. Bye.
Thank you for listening to today's episode of Psych Talk. I hope you found so much value. If you loved what you heard or gained some knowledge, I would love for you to take a screenshot, put it on your Instagram stories, and tag me at Jessica Lee, PhD. Additionally, I would be honored if you leave a review and 5-star rating so I can continue to help this podcast grow. If you are not already, follow me on Instagram and join my Facebook community, Grow Through What You Go Through. Thank you for joining me today, and I cannot wait for you to join me during the next episode. Remember, you are loved, you are worthy, and you are braver than you know.